Welcome to this short presentation on how to implement the updated international expert consensus guidelines on physiological interpretation of CTG in our daily clinical practice. So we found that in part 1 we discussed the principles behind what is stated in the guidelines. This part 2 is about application of physiological tools to help improve outcomes for women and babies. So this is the international consensus guidelines on physiological interpretation of CTG. It incorporates both recent evidence on chorioamnionitis and different types of hypoxic stress. I'm very grateful for the 15-member editorial board and the 50 experts on CTG in an international consensus panel from more than 20 countries from 6 continents for their hard work. And we have made this available as open access to disseminate knowledge across the globe. So my special thanks to the editorial board as well as the 50 members of the International Consensus Panel. Now, before I go to part 2, I strongly recommend that one should watch the part 1 to understand the basic concepts in the guidelines. And this is the QR code. In case you haven't watched part 1 of this presentation, please do watch, because it sets the basis for what we are going to discuss in this presentation. So just to quickly recap, the guideline doesn't classify CTG traces based on mixing up random features and giving them random time limits like 90 minutes, 50 minutes, because each fetus is different. Each human fetus has different reserves and different intrauterine environment and different maternal environment. And therefore, we cannot simply have timelines for all fetuses and force them to follow our timelines, which are also changing in each guideline. So this international expert consensus guidelines on physiological interpretation of CTG classifies CTG features by considering a combination of features or sequence of features in order to determine different types of hypoxic stress and inflammatory stress and non-hypoxic causes of fetal compromise. So this is a no hypoxia. You can have occasional decelerations as long as they are not repetitive. We always look at the stable baseline and reassuring variability, and we classify those babies who are showing us a stable baseline, reassuring variability, and cycling without repetitive decels as no hypoxic stress. So they are not exposed to any tissue hypoxia. They may be exposed to hypoxic stress, but not tissue hypoxia. Then we have the second group. They come to us with pre-existing placental failure, and that is the chronic hypoxia group. And the guideline tells us what the features are to recognize chronic hypoxia. They are a combination of features: higher than expected baseline, reduced variability and absence of cycling, and repetitive shallow decelerations. And the guideline also recommends what action that needs to be taken if chronic hypoxia is diagnosed. Then we also included a section on relative utero-placental insufficiency of labor, or RUPI-L, because we know that vast majority of fetuses have enough placental reserves to withstand the progressively increasing hypoxic stress of labor, as the contractions are getting stronger and longer as the labor progresses. But we also know that there is going to be a group of fetuses who do not have the full reserve. They have got subclinical placental failure, or their demand is higher than normal, for example, macrosomic fetuses. And therefore, those fetuses have to be recognized so that we can optimize care for those fetuses. And that is the reason why the guideline has included RUPI-L in the classification system to look at fetuses with subclinical placental failure or increase in the demand, and to determine what features these fetuses might show us as the uterine contraction progressively increases in frequency, strength, and duration. Then we also have a gradually evolving hypoxic stress. This is the commonest hypoxic stress faced by human fetuses, and that's because the human labor is about 8 to 10 hours on average, and the stress usually evolves slowly. The contractions are usually 1 in 2 in 10 minutes in the latent phase, and then they are going to about 3 to 4 with increased duration, going to about 4 to 5 with stronger duration in second stage. And therefore, this is the commonest type of hypoxia. And again, the guideline talks about what are the features of compensated gradually evolving hypoxia and decompensated gradually evolving hypoxia, and to how to deal with that situation. And in second stage of labor, as the speed suddenly increases due to increase in the strength of the contractions due to Ferguson's reflex, as well as active maternal pushing, often about 10% of fetuses might show features of subacute hypoxic pattern. And the guideline tells us if this pattern happens in the first stage of labor, what should we be doing, and second stage of labor, what we should be doing. Then the third type of hypoxia is the acute hypoxia, a sudden cessation of oxygen. And based on what we find as a cause, if it is irreversible like abruption, uterine rupture, or the features that we see on the CTG trace prior to the onset of prolonged deceleration and the first 3 minutes of the prolonged deceleration, the guideline makes certain recommendations as to how urgently we should treat the matter, and also how we must respond by looking at the etiology of the prolonged deceleration. So you have just looked at chronic hypoxia, gradually evolving hypoxia, compensated, decompensated, subacute hypoxia, RUPI-L, and acute hypoxia. And then the guideline has included in October 2024 a section on chorioamnionitis and what features you would see on the CTG trace in chorioamnionitis. And also there's a section on other abnormal CTG patterns. For example, the double mountain peak sign that you would get in second stage of labor if someone is wrongly monitoring the maternal heart rate as fetal heart rate. There will be large amplitude accelerations coinciding with the peak of the contractions, giving the appearance of one mountain above the other mountain, the double mountain peak sign. And also we have Poole Shark Teeth pattern, sinusoidal patterns, etc. So once we understand the principles of pathophysiology and understand the classifications which have been recommended to identify different types of hypoxia and other non-hypoxic causes of fetal compromise, then it is logical that the next issue is to develop practical tools to help frontline midwives, nurses, and obstetricians to implement these guidelines in their daily clinical practice. And this is why these tools have been developed and incorporated in the guideline for easy access. So let's just take a step back and look at the principles behind these tools. So if you are considering antepartum period, it's a long period of approximately 9 months. And therefore, we have to assess fetal growth. In terms of hypoxemia, we are thinking of a slowly developing hypoxemia due to gradual and progressive destruction of the placenta or insufficiency of the placenta, and there may be non-hypoxic causes of fetal compromise, mainly inflammation, chorioamnionitis, and the rare causes include fetal maternal hemorrhage, chronic fetal anemia, etc. So we need to have a tool to recognize antenatal causes, and that is our caution checklist, which we'll be seeing very soon. Then as the fetus comes to us at the onset of labor, when the hypoxic stress commences, as the contractions start to cut off uterine blood supply as well as may cause compression of the umbilical cord, we need to ask a question: is this fetus fit to undertake the progressively hypoxic journey of labor? But that is by checking the functions of three organs: the brain, the heart, and the placenta. And this is the fetal monitoring checklist we'll be looking at. Finally, if we have deemed that a fetus is fit for labor, their problem is not over, because during labor, the uterine contractions are progressively getting stronger, longer, and more frequent. That means all the maternal spiral arterioles that traverse the myometrium to supply the placental bed may be squeezed longer for a longer period of time and more frequently. And that might give rise to a gradually evolving hypoxia to a human fetus. And in other words, human labor itself is a stressful situation. Vast majority of fetuses deal with that stress without a problem, but we need to have tools to recognize those fetuses who are experiencing a stress response and differentiate their stress from compromise. And during labor, as the membranes rupture and the cervix opens, there's enough time for the bacteria from both the upper and the lower vagina of the mother to ascend and cause infection. And therefore, we also need to recognize features of inflammation. And this is where the next checklist is there during labor, which is called How is this fetus tool, or the Intrapartum Fetal Assessment Tools. So let's look at Antepartum Fetal Assessment. So for 9 months, the main assessment is clinical assessment predominantly, but the mother is telling us, and mother's history examination is a crucial part of antenatal fetal assessment. Then ultrasound scan would look at the growth, including amniotic fluid volume if there is a chronic uteroplacental insufficiency, and Doppler blood flow indices to look at blood flow and the resistance in the umbilical artery, middle cerebral artery, and the ductus venosus become important, because we need to understand and recognize evidence of redistribution, and also based on the pulsatility of the middle cerebral artery blood flow, we will be able to detect if there's any fetal anemia going on. And very recently, Roberto Romero's group have given rise to the concept of sludge. If there is chorioamnionitis, you might find amniotic fluid sludge due to purulent or thick material. Then we have fetal assessment, and antenatally, please remember, we cannot use standard CTG guidelines, which classify CTGs into normal, suspicious, pathological, because they are made for intrapartum assessment. Antenatally, there is no repetitive strong contractions to squeeze the cord, and therefore you will not find big decelerations. And this is why antenatally it is often a cardiograph and not a cardiotocograph. And computerized CTGs may help with short-term variability or STV. But remember, that has limitations too, because a human fetus in the antenatal period doesn't only have placental failure as a problem to give you CNS depression and reduce short-term variability. In fact, fetuses with inflammation, which is a large group in the antenatal period, may experience neuroinflammation, which will increase the normal variability. And also the short-term variability may be detected by the computer, which is programmed in NICE guideline or similar guidelines which have got population-based parameters which have no chance of individualizing care, and they might give a false reassurance saying that STV is normal. And this is the reason we are going to use caution checklist. So this is the caution checklist. So it has got C, which is cycling, to detect whether the alternative periods of active and quiet sleep cycles characterized by normal and reduced baseline variability is present in the antenatal period, especially after 28 weeks. Then it talks about accelerations, because in the antenatal period, in the absence of hypoxemia and inflammation, a human fetus has to move. Then unstable baseline if there's a myocardial problem, tardy decelerations, because it's often the placental problem that causes compromise in the antenatal period and not a repetitive cord compression. So then we have irritability of the uterine myometrium, which is very crucial because both fetal maternal hemorrhage, concealed abruption, and chorioamnionitis can present with uterine myometrial irritability. And we also have to see whether the baseline heart rate is inappropriate for gestational age. Then we have to then look at the overall history, because that gives us enough information and features of non-hypoxic causes of fetal compromise. So that is your caution history, and here you can see there's myometrial irritability, there's zigzag pattern due to chorioamnionitis. In the same way, you can have myometrial irritability and 10% rise in the baseline at term, and therefore the baseline is inappropriate for the gestational age at 41 weeks. However, you could see the normal guidelines will miss this baby because of having a wide range 110 to 160 for the baseline, and fetuses with inflammation due to increased neuronal metabolism, they rarely reduce the baseline variability. They maintain the baseline variability but would not show presence of cycling. The deep sleep cycle would be lost. And this is why standard guidelines and computerized CTGs often miss these fetuses, causing poor neonatal outcomes. And here, let's use the caution checklist. This is the woman who is coming to at 38 weeks with a history of reduced fetal movements. And the caution checklist would not be fooled by the large range that is given for the baseline and the variability. And here you can see the variability would be 5 to 25 beats per minute, but the fetus cannot go into deep sleep. And if you look at the tocograph, you could see the reason. It is chorioamnionitis, myometrial irritability, low voltage complexes, and therefore the caution checklist would help to save this baby on time instead of sitting on this trace calling as suspicious, giving fluids to the wrong person, the mother, which often results in poor neonatal outcomes. And in the UK, the Each Baby Counts reports, repetitive reports, 4 of them have shown that approximately 1,000 babies had severe brain damage or died either intrapartum or in the early neonatal period, and 70% of them approximately had substandard care. And it is very sad, because if these tools have been used to recognize the problem, instead of just calling it normal, suspicious, pathological, and using the same guideline in the antenatal period and intrapartum period, we are losing, sadly, loss of babies. So the next question is, if a woman comes to us and she has just started labor, or she is coming for induction of labor, when we know that we are going to increase the stress to the fetus, hypoxic stress, the question is this fetus fit to undertake the progressive hypoxic journey of labor? The fetus also may come to us with pre-existing inflammatory stress or non-hypoxic stress. And that is why we have designed the fetal monitoring checklist to detect these problems. so that we can answer this question. Sorry. So this fetal monitoring checklist is based on our publication about 10 years ago, where we looked at how to assess the central organs of the fetus, how to assess both the autonomic and somatic nervous system of the fetus, and to look at individualization of care so that we can assess 3 organs, as we said, the heart, the brain, and the placenta, to ask the question, is this fetus fit to undertake the progressively hypoxic journey of labor? So let's go and look at how this system works, this checklist works. And if you see this CTG, and this is a woman who is gravida 2 para 1, 40 weeks plus 4 days, admitted with spontaneous onset of labor. She is coming to us with a history of reduced fetal movement. You can see how the standard guidelines will fail. Excuse me. And that's because they have a wider range. But based on physiology, we know that fetuses at 41 weeks, they shouldn't have a baseline more than 140 beats per minute due to a strong vagal dominance. And the decelerations these fetuses show due to chronic hypoxia are very shallow. They wouldn't even fit into the definition of more than 15 beats, 15 seconds stated by the guideline, because the fetus has lost all the compensatory responses. They are unable to mount a strong deceleration, which is a cardioprotective reflex. But if we use the fetal monitoring checklist, which has been recommended from the guidelines, so this is from the guideline, you could see that immediately we could pick this fetus up and we could make a diagnosis. Suspicious CTG is not a diagnosis. Pathological CTG is not a diagnosis. Those classification system is based on just grouping random features together, whereas chronic hypoxia is a diagnosis because we are combining the pathophysiological features, higher than expected baseline, reduced variability and absence of cycling, and presence of shallow deceleration. And once the diagnosis is made, it's easy to manage. You would say avoid further stress, and if your theater is busy, you would give tocolysis to abolish any ongoing contractions. Again, those of us who do physiological interpretation of CTG, we know that this is Poole Shark Teeth pattern, and that is due to acute fetal hypovolemia and hypotension. And the commonest cause during labor is ruptured vasa previa, but it can happen due to sudden fetal-maternal hemorrhage. It can happen due to abruption. But in this case, you can see there is Poole Shark Teeth pattern, and there is also myometrial irritability, and this is what we call teeth on teeth pattern. There are teeth here and there are teeth here. So teeth on teeth pattern, and that is only placental abruption due to irritation and loss of fetal blood volume. Again, when a woman comes, if someone had used, these are some of my sad medical legal cases, but if an obstetrician and midwife had understood physiology and used physiological tools, these fetuses would not have died or had suffered serious brain damage, because we would have made the diagnosis. And once we make a diagnosis, then we know what to do. Then we come to intrapartum fetal heart rate changes, and we know the fetuses can expose to hypoxic stress, which can happen over a number of hours. As I said, gradually evolving hypoxia is the commonest type of hypoxia. Then the hypoxic stress can come quite rapidly in the first stage of labor if we use oxytocin or prostaglandins to induce or to augment, and in second stage of labor due to active maternal pushing. And this kind of hypoxia comes usually within 30 to 60 minutes. It's quite rapid. If there's a sudden and profound interruption of oxygen, for example, uterine rupture, placental abruption, or acute maternal hypotension, then we get into a situation of acute hypoxia. And apart from hypoxic stress, intrapartum fetus can experience inflammatory stress. It could be due to maternal infection, but what we mostly worry about is fetal inflammation and ascending infection, which will not be presenting with maternal tachycardia or pyrexia, but causes significant problem for the fetus. And then anytime you could have other non-hypoxic causes like fetal-maternal hemorrhage, fetal cardiac rhythm abnormalities, including supraventricular tachycardia, congenital heart blocks, and also you can have intrauterine fetal stroke, which need immediate attention. So we know these are pretty much the different types of compromise the fetuses undergo due to underlying pathology. And RUPI fits in between gradually evolving hypoxia and subacute hypoxia, because these fetuses have a relative uteroplacental insufficiency, and therefore as the stress increases during usually active first stage of labor, second stage of labor, they might show features suggesting that they are unable to compensate and they need intervention. And by looking at this trace, I'm sure all of you who are experts in fetal physiology, you would immediately say this is a gradually evolving hypoxia because there are repetitive decelerations, and because there is stable baseline and reassuring variability, this is a compensated gradually evolving hypoxia. And the fetus is also showing us that it is in a very steady state because there was no need to release catecholamines yet. So if you use the Intrapartum Fetal Assessment Tool, which is recommended by the guideline and it is part of the guideline, you would say that at the beginning, it's always important to write down what the baseline heart rate was at the beginning, and this is the baseline heart rate now, and therefore you wouldn't find any change in the baseline. And if you look at the decelerations here, they are very quick to fall and quick to come up. And they are very, you can see, quick to fall, and these are the quickly decelerations due to cord compression. So that's what you would write as quickly deceleration. And there's no 10% rise in the baseline. There is nothing to suggest that CNS, central nervous system, is getting decompensated based on the features. And you would make a diagnosis of a gradually evolving hypoxia, and then you would make a plan saying that continue observation, looking for a 10% rise in the baseline. Because we know based on fetal pathophysiology, just like us in the gym, if this fetus needs more oxygen due to increasing stress, the fetus has to increase the baseline due to catecholamines. Or if the fetus has an inflammatory stress, if bacterial infection happens due to increased metabolic rate, every degree rise in the baseline will increase the heart rate by approximately 10%. So at the moment, we haven't had it. In this case, they started oxytocin. You could see, looking at the TOCO, the contractions were all coupling. And you can see the baseline, which was initially 120, it has gone to about 160, 170. So it's more than 10% increase in the baseline. Obviously, if you understand fetal physiology, this is a gradually evolving hypoxic stress with catecholamine response still compensated because the baseline still remains stable and the variability remains reassuring. And these are all quickly decelerations. If they have used this tool for this fetus, they would have immediately realized that the baseline has gone up by over 10%. And once you understand it's an evolving hypoxia, the management is simple. It's about reducing the stress to reduce the catecholamine response and allowing the labor to continue. But this is a case where the obstetrician and the midwife, they were following NICE guidelines, and therefore they didn't understand physiology. So they thought this is repetitive decelerations, two intermediary or non-reassuring features, pathological CTG. A trainee was requested to go and cut the skin of the scalp. And this is the problem, where when we don't understand what we do, we have to do crazy things in clinical medicine. So repetitive decelerations, the guideline said pathological CTG, take a blade and cut the skin of the scalp. And then if the skin is normal, continue doing FBSs every hour. That's what the national guideline said. Unfortunately, though Americans stopped using fetal blood sampling 30 years ago, there were 3 repetitive fetal blood sampling, Cochrane systematic reviews stating clearly that fetal blood sampling did not improve perinatal outcomes or decrease emergency cesarean section. Unfortunately, despite a study from Sweden suggesting that repetitive fetal scab lactate doubled the cesarean section rate for women, and a multi-center trial in the UK that showed that there was a 60% increase in cesarean sections without improvement in perinatal outcomes, unfortunately, the UK guideline did not stop fetal blood sampling until 2022. So from 2001, when it was first recommended, it was repeated despite scientific evidence showing that it was harmful. And lots of women had unnecessary cesarean sections, and lots of fetuses had perinatal brain damage or sadly died because this test, though they thought, some senior obstetrician, that taking the blood sample from the skin of the scalp reflected the brain, because the skin of the scalp was close to the brain, which is nonsensical because skin is a non-essential tissue, and the skin of the scalp is supplied by branches of the external carotid artery. And in the medical school we learned that the brain is supplied by branches of internal carotid artery, and therefore taking a small sample from the skin is not going to reflect the brain at all. We don't represent central organ oxygenation. If you are in the gym, if you're running a marathon, you would release catecholamines to constrict the fetal blood, your skin blood vessels to supply your central organs. So your skin of the periphery, skin of the scalp or skin of the arm, would become acidotic because it loses the oxygen to supply the central organs, so you could continue running. And it will go into anaerobic metabolism, produce high lactate and low pH, which is normal physiological responses. In the same way, human fetuses would do the same. When they are exposed to hypoxic stress, when they release catecholamines, they divert the oxygen by constricting all these skin blood vessels in the dermis to the central organs. So if a crazy obstetrician goes and cuts the epidermis and the dermis on here superficially, that will be acidotic, and that is normal. And the poor woman is going to have an unnecessary cesarean section based on this wrong result, treating physiology as pathology. Unfortunately for this fetus, knowledge was scarce in that labor ward, and therefore they cut the skin. They convinced themselves that they were doing well. And obviously when the oxytocin was going on, after gradually evolving hypoxia, you could see the fetus was now going into subacute hypoxia. Again, by guidelines that they were using, national guidelines, it was a pathological trace. And therefore, the poor resident, the trainee, was asked to go and cut the skin again. Because in the UK, for some reason, they said you can do 3 times. So this was a second attempt. And obviously, this fetus is having rapidly evolving hypoxia. The skin is going to be normal. There's no time for catecholamine response and vasoconstriction. So the fetal blood sampling was normal. But those of us who understand basic pathophysiology, we know this is a subacute hypoxia, and there's also ZigZag pattern telling us that there's CNS instability. And all this fetus needed was to stop that stress, reduce the oxytocin. So they missed the oxytocin reduction. They continued because fetal blood sampling was normal. If they had used this tool, they would have recognized subacute hypoxia. And as expected, the outcome was very bad because fetuses don't care about how much of oxygen they have in the skin. They care about central organs. And once we get ZigZag pattern, we know that there is autonomic instability. It's the brain that is getting affected. And we have published on ZigZag pattern to show there's a 11-fold increase in neonatal admission. But because the UK guideline until 2017, for some reason, contrary to all other international guidelines, which defined variability as 5 beats to 25 beats per minute as normal, UK was the only country which went outside human physiology and, whether it's ego or ignorance, defined baseline variability as more than 25. And because of that flaw, deep flaw in the guideline, anything that was more than 5 was considered as normal, because the original definition from 2001 was any baseline variability more than 5 was considered as normal. So lots of babies were missed. In my medical legal practice, I have had several babies who sadly died or got damaged because this increased variability was considered by midwives and obstetricians working in the UK as normal, because the national guideline simply put one number, more than 5 was normal. So anything more than 5, 30, 40, everything was considered as normal. So this, as expected, after the brain, there was a terminal bradycardia and the poor outcome. But if they had used an intrapartum assessment tool that clearly tells about different types of hypoxia, they would have saved this baby. And all this fetus required was to reduce the stress. So if you are a resident or junior midwife, if in your hospital, thankfully, except a few European countries and 2 Commonwealth countries, Canada and Australia, most of the countries have now stopped fetal scalp blood sampling based on better knowledge and based on scientific evidence, including the UK. So if you are thinking of hypoxic stress, please remember, as the fetus increases the heart rate by releasing catecholamines, the same catecholamines are going to the skin, which is a peripheral non-essential organ, and divert the blood from the skin to the central organs. And therefore, if you take a sample in the skin, it is going to be abnormal for pH, but the fetus is normal, because the fetus would continue to show a stable baseline and reassuring variability. And there are lots of publications, even we published a paper 6 years ago, that showed that if you have repetitive variable decelerations or late decelerations, if the baseline variability was normal, the risk of acidosis was 0%. So in hypoxic stress, often you will find an abnormal lactate, high lactate or low pH, but the fetus is normal, requiring no intervention. Whereas in chorioamnionitis is exactly opposite. Bacterial toxins and cytokines cause peripheral vasoparalysis, and that's why you get warm peripheries in sepsis. Such a fetus, because there's vasoparalysis, would supply lots of oxygen to the peripheral tissues at the expense of central organs. That's why they get into hypotension and multi-organ failure. But the skin is very warm because the skin is getting normal blood supply, excessive blood supply. So you will have normal lactate and normal pH in chorioamnionitis if you do a fetal scalp sampling, but it's an abnormal fetus is going to collapse and die. So you can see why, by doing fetal blood sampling, on one hand, in countries where they have done this test, if you look at the emergency cesarean section rate, it is rocketing high. We are paying the price for it in terms of uterine rupture, placenta accreta spectrum. Whereas in countries where they do fetal blood sampling, they are also failing these fetuses with chorioamnionitis, and they are collapsing either inside the uterus or immediately after birth, leading to poor perinatal outcomes. So that's why the international expert consensus guidelines on physiological interpretation of CTG, based on current scientific evidence, based on basic knowledge of anatomy, physiology, and biochemistry, have actively recommended that fetal blood sampling has no role in contemporary obstetric practice. I hope that this illogical, historical, nonsensical practice is stopped to save both women and babies. So let me finish by saying we have 3 tools in the guideline. The first one is the caution checklist that is to be used in the antenatal period when there are no repetitive contractions. We are looking at both hypoxic and non-hypoxic causes. Whereas as the fetus is coming to us with the onset of stress or for induction of labor, we use the "Is this fetus fit to undertake the journey of labor?" to assess the brain, heart and the placenta by using the fetal monitoring checklist. And finally, once we deem that the fetus is fit for labor, every time when we look at the CTG, we need to understand and ask the question, how is this fetus, by using the Intrapartum Fetal Assessment Tool. So these 3 tools are there to help us with optimizing fetal surveillance right from the antenatal period and also at the onset of admission for induction of labor or with contractions, as well as during labor, so that we do not miss these fetuses by illogically classifying them into normal, suspicious and pathological. Thank you very much on behalf of the editorial board of International Expert Consensus Guidelines on Physiological Interpretation of CTG and the 50 CTG experts from over 20 countries who worked very hard to produce this guideline with the intention of improving outcomes for women and babies by reducing unnecessary intrapartum cesarean sections and operative deliveries, by understanding the features of fetal compensation, at the same time to prevent cerebral palsy, long-term neurological deficits and perinatal deaths by recognizing the features of fetal decompensation. So thank you very much for your patient hearing.